Welcome back to the deep dive. We've got something really specific and hopefully super useful for you today.
Yeah, we're taking a set of revision notes specifically on thyroglossal cysts and breaking them down.
Exactly. The mission is to pull out the absolute core knowledge, make it memorable, make it stick. We're turning dense notes into, well, something easier to digest for revision.
Absolutely. Cutting through the detail to get to the high-yield stuff you need, making it clear and quick.
Okay, let's unpack this then. Thyroglossal cysts. Started right at the beginning. What exactly is one, according to these notes?
So the notes define it pretty clearly. It's a congenital abnormality.
Meaning you're born with the potential for it.
Right. It comes from remnants, basically leftovers, of the thyroglossal duct. That's a structure from when you're developing as an embryo.
And how does that leftover bit actually present? What would you see?
Typically, it shows up as a cystic mass, so fluid-filled, usually. And the key is its location midline neck.
Midline. Got it. Often near the hyoid bone, the notes mention.
That's a very common spot, yes, near the hyoid.
And who usually gets diagnosed? Kids. Adults.
Mostly seen in children and young adults. And there's that classic sign everyone learns.
Ah, the movement. Tell us about that.
Yeah, the cyst characteristically moves upwards. It elevates when the patient swallows or sticks their tongue out.
That midline lump moving with the tongue, that's the mental picture.
Definitely a key diagnostic clue.
Okay. And are these things harmless, or can they cause problems, complications?
They can definitely cause issues. The notes mention infection as a big one. The cyst can get inflamed, painful, swell up.
Makes sense. Anything else?
Also, cutaneous fistulas can form. Those are little tracts opening onto the skin.
Right. So
No.
because of these potential problems, surgery.
Yes, surgical excision is generally the way to go for definitive treatment and to prevent those complications.
And just quickly, the notes mentioned different subtypes or locations?
They did, yeah. 6 variants listed based on where along that developmental path the remnant is: infrahyoid, suprahyoid, juxtahyoid.
So below, above, or right next to the hyoid.
Exactly. And also intralingual, meaning within the tongue itself, suprasternal, down near the chest bone, and even intralaryngeal, which is rarer.
Wow. Okay, so usually midline below the hyoid, but it could be elsewhere along that path.
Precisely. Helps explain the variations you might see.
Let's dig into the why then. Etiology and pathophysiology. How does this actually happen embryologically?
So the cause, the etiology, is basically that the thyroglossal duct doesn't close up and disappear like it's supposed to during development.
It's meant to just go away.
That's right. You see, the thyroid gland starts developing way up near the base of the tongue at a spot called the foramen cecum.
Okay.
Then it travels downwards, descends to its final spot in the lower neck, and while it's migrating, it's connected back to the tongue by this temporary tube, the thyroglossal duct.
Like a little tether.
Kind of, yeah. Normally that duct just degenerates, atrophies completely before birth, but if bits of it stick around.
That's where the cyst forms.
Exactly. Persistence of those duct remnants leads to the cyst. Pathophysiology-wise, the notes say they're often lined with epithelial cells, maybe contain fluid, mucus.
And sometimes even thyroid tissue.
Yes, that's possible too. And symptoms usually pop up when it gets bigger, often because of, infection or inflammation.
Okay, that developmental journey really explains the location and the potential problems. What about risk factors? Is it genetic? Anything you do that causes it?
Well, the notes are pretty clear on this. It's mainly congenital, a developmental hiccup, really.
So not really linked to lifestyle or environment.
Doesn't seem so, based on this source. The only thing mentioned is that maybe a positive family history could slightly increase the risk.
But mostly just bad luck during development.
That's the main takeaway. Considered sporadic for the most part.
Right. Let's talk numbers then. Epidemiology, especially focusing on the UK data provided. How common are we talking?
The numbers are quite telling. It's cited as the most common congenital neck lesion.
Wow, most common.
Accounts for about 70% of those congenital abnormalities in the neck. So pretty significant.
70%. So if a child has a lump in the neck they were born with, there's a good chance it's this.
A very good chance, yes. Diagnosis usually happens in the first, say, 3 decades, but over half are found before age 10.
Makes sense if it's congenital.
It does. Now, if you look at all neck masses, not just congenital ones, it's a smaller slice, maybe 2–4%. But still common enough, and it's relatively rare to see it first diagnosed in older adults.
So really common in kids, less so later on. knowing that prevalence is definitely useful.
Helps keep it high on your differential list for a child with a neck lump.
Okay, so we know what it is, why it happens, who gets it. Let's paint the picture, clinical features. What do you actually see and feel on examination?
The classic presentation, as we said, is that painless midline neck swelling or mass, usually below the hyoid bone.
Painless is key, unless it's infected.
Right. And on palpation, it typically feels soft, maybe a bit fluctuant, like there's fluid inside, and it should be mobile.
Mobile side to side, but tethered vertically.
Sort of, yes. And then there's the crucial sign.
The movement.
Again, always come back to it. It gets more prominent, moves up when the person swallows or pokes their tongue out.
And the notes explain why that happens.
Yes, it's because the cyst is attached to that thyroglossal tract, which connects up towards the tongue base and is linked in with the larynx via fascia. So tongue moves, larynx moves, cyst moves with them.
The anatomy makes the sign make sense.
Yeah.
Brilliant. What if it does get infected? How does that change things?
Oh, infection changes the picture completely. It stops being painless, becomes tender, red, swollen.
Looks angry.
Exactly. You might get pus draining, maybe even a sinus opening to the skin, and the patient might have difficulty swallowing, dysphagia or voice changes, dysphonia, fever, enlarging mass, all signs of infection.
So infection turns it from a quiet lump into an acute problem.
Definitely. And there's that rare but important point about airway risk.
Ah, yes, if it's really high up.
Right, the intralingual variant. If it's large or inflamed up near the airway, it could potentially cause obstruction. Rare, but critical to be aware of.
Okay, so midline lump moves with swallowing tongue. Yeah. Usually painless unless infected. Rare airway risk if high up. Got the picture. Now, differential diagnosis. It's a lump in the neck. What else could it be?
Yeah, super important. Just because it's midline and moves doesn't automatically mean it's a thyroglossal cyst. The notes list quite a few mimics.
Like what?
Other midline things like dermoid cysts, maybe lipomas, certainly enlarged lymph nodes, lymphadenopathy, and unfortunately you always have to consider malignancies.
Okay, what about things related to the thyroid itself?
Good point. Definitely need to differentiate from general thyroid swellings or, crucially, ectopic thyroid tissue.
Where the thyroid tissue itself is in the wrong place, maybe inside that cyst.
Exactly, which goes back to that embryology again. Other possibilities mentioned are things like branchial cleft cysts, although they're often more lateral.
On the side, yeah.
Cervical teratomas, vascular issues, salivary gland tumors. It's a broad list initially.
So careful evaluation is key. And the notes specifically mention cancer within the cyst itself.
Yes, TGDC carcinoma. It's rare, but it happens. It's one reason why getting tissue, often through surgery, is important.
But the prognosis is usually good if it is that.
The notes say the mortality rate is generally low, which is reassuring.
Okay. And dermoid cysts, how are they different?
They tend to arise from a different embryonic layer. Ectoderm can be in various places, not just midline neck, and contain different stuff, skin bits, hair.
Different contents. Got it.
Yeah.
So faced with this midline lump, how do you investigate? What tests do the notes recommend?
Starts with a good clinical examination, of course. Feeling the mass, checking mobility, doing the swallow-tongue protrusion test, and really importantly, palpating the thyroid gland itself.
Why is checking the main thyroid gland so vital here?
Because, as we said, the cyst can contain thyroid tissue, or rarely, the lump is the patient's only thyroid tissue, ectopic thyroid. So you need to confirm the main gland is present and feels normal down in its usual spot.
And if you can't feel the thyroid properly?
Then, imaging becomes even more crucial, according to the notes, to locate the normal thyroid or confirm if the lump is ectopic thyroid tissue before any surgery is planned. You wouldn't want to remove someone's only thyroid gland by accident.
Makes absolute sense. Critical point.
Right.
What imaging is best?
Ultrasound is often used first. It's readily available, but the notes suggest CT might be preferred for really defining the size, location, contents, and importantly, tracing that tract upwards.
Seeing the whole picture. What about getting a sample, FNA?
Yes, fine needle aspiration or biopsy. FNA can help confirm the diagnosis by looking at the cells and fluid, and it's key for ruling out malignancy.
So exam, imaging, maybe FNA. Are there other more specialized tests mentioned?
Yeah, a few for specific situations. Thyroid function tests, TFTs, if you're worried about the thyroid gland's status. A fistulogram if there's a draining sinus to see where the tract goes.
Injecting dye, right?
Exactly. Thyroid scanning if you suspect ectopic tissue.
Yeah.
And then things like barium swallow or a laryngoscopy might come in if the differential diagnosis points towards other issues like branchial cleft problems or certain cancers, but they aren't routine for a typical thyroglossal cyst workup.
Okay, so core workup is exam, imaging, maybe FNA, tailored extras if needed. Once confirmed, what's the management? You mentioned surgery.
Yes, the notes are definitive. Surgical excision is the treatment.
And it's not just scooping out the cyst. There's that specific procedure.
Correct. It's called the cyst trunk procedure. It's crucial because it addresses the underlying embryology.
How so?
It involves removing the cyst itself, plus the central portion of the hyoid bone and the entire thyroglossal tract right up to the base of the tongue, all done under general anesthesia.
Taking out part of the hyoid bone sounds quite involved. Why is that necessary?
Because that tract often passes right through or is stuck very close to the hyoid, if you leave that central bit of bone and the tract attached to it behind, the cyst is much more likely to come back.
So removing the hyoid segment ensures you get the whole tract, prevents recurrence.
That's the principle, yes. Get the whole developmental pathway.
And why do the surgery? The notes list reasons.
Multiple reasons. 1, definitive diagnosis from the tissue. 2, preventing those complications, infection, pain, airway issues, fistula. 3, addressing any cosmetic concerns. And 4, removing that small risk of malignancy.
Diagnosis, prevention, cosmetics, cancer risk. Makes sense. So cyst trunk's operation is the gold standard.
It is. The notes mention endoscopic surgery sometimes being considered, perhaps for better cosmetic results, but cyst trunks is the established technique for minimizing recurrence.
Cyst trunks, cyst, hyoid, tract. Easy to remember. What about after the surgery? Prognosis.
Generally excellent, according to the notes.
That's good. And recurrence rates with the cyst trunk.
The notes quote around 6%. Which is pretty low.
6%?
Yeah.
Not bad.
And they mention that some surgeons might do a slightly wider dissection in the central neck to potentially lower that risk even further, but 6% is the standard figure to know for the cyst trunk.
Okay. Now what can go wrong? Complications either before surgery or after.
Before surgery, the main thing highlighted is infection or abscess formation in the cyst.
And that makes surgery harder.
Yeah. The notes explicitly state that active infection can worsen outcomes after surgery, make the dissection trickier, increase risks.
So ideally, you treat the infection first, then operate.
That would generally be the approach, yes. Post-operatively, the potential issues are things like wound infection, hematoma blood collecting under the incision.
Bruising, basically.
A significant collection, yeah. And of course, recurrence, even with the cyst trunk, though it's less common.
What makes recurrence more likely, according to the source?
Mainly linked to the surgery itself if the technique wasn't quite perfect or if the cyst ruptured during the operation.
If it bursts open.
Exactly. And factors that make rupture more likely include previous infections, if someone's tried to drain it before, or if the cyst is really stuck to the skin.
Makes sense. Those would all make a clean, en-bloc removal more challenging.
Precisely. Wound infections are also mentioned as a risk, especially if rupture happens or if, very rarely, the pharynx gets nicked way up high during the tract dissection.
So careful surgery and managing infection beforehand are key. Anything else on complications?
Just the reminder about needing good follow-up care, monitoring healing, watching for any signs of infection or recurrence down the line.
Right. Follow-up is always important. Okay, let's shift gears slightly. We're treating this as revision material. Mnemonics, practice questions, great revision tools. The source didn't give specifics, but how could someone use this info to make their own?
Yeah, it's a shame there weren't specific examples, but you're right, the content is perfect for it. Like that list of differential diagnoses for a midline neck mass. You could easily pause and try to make an acronym for dermoid, lymphadenopathy, thyroglossal, thyroid issues, maybe lipoma. Something simple to jog your memory.
Good idea. Or frame a question.
Definitely. Like, you see a 5-year-old with a soft midline neck lump that rises when they stick their tongue out. What's the top diagnosis and what's the name of the standard operation? Test yourself.
Yeah, or just mentally rehearse the key facts, the 70% congenital figure, the 6% recurrence rate, the 3 parts of the cyst trunk removal.
And remember that built-in memory aid we talked about linking the embryology, the thyroid's journey down from the tongue, to why the cyst moves with swallowing. Understanding the why makes the what stick.
That connection is definitely powerful.
Yeah.
Okay, nearly there. As a final thought, something provocative for you listening to mull over, building on what we've covered.
How about this? Given that these cysts arise from the thyroid's developmental path and can contain thyroid tissue, If you find a suspected thyroglossal cyst but cannot feel a normal thyroid gland in the usual place, what major concern should immediately jump to mind?
And how would that concern drastically change your next steps, even before thinking about surgery for the cyst itself?
Exactly. It forces you to connect the dots between embryology, clinical findings, and potential serious implications for management. It's about that deeper understanding.
Knowing the why informs the what to do next. Perfect.
Couldn't have said it better.
Well, that brings us to the end of this particular deep dive. We've covered thyroglossal cysts, from the definition and the embryology, right through to management and complications, all based on those revision notes.
Hopefully, distilling it down like this has made it clearer, more memorable, and really high yield for your study time.
We really hope it helps you feel more confident with this topic. And listen, if you are revising for exams like the MSRA and looking for more excellent resources, do check out passmsra.com.
And also freemsra.com for, well, free resources too. Both are great platforms.
Definitely worth a look. Thanks so much for joining us on the deep dive.
Until next time, happy revising.